Our next speaker is going to be Dr. Susan Buchbinder from the University of California in San Francisco, and she's also the co-PI of the San Francisco Bay Area Clinical Trials Unit for NIAID. And Susan's going to be talking to us about common pre-exposure prophylaxis questions and cases. Dr. Buchbinder.
Thanks so much. I'm really pleased to be leading this case-based presentation on pre-exposure prophylaxis. So let's get started. So these are my disclosures. And now these are the learning objectives. So we will talk about same-day PrEP starts. We're going to talk about 2-on-1 PrEP regimens. We're going to talk about the relative advantages and disadvantages of TDF-FTC and TAF-FTC PrEP, as well as a number of other issues. So let's start with a question to the audience. Do you start PrEP on the same day or do you wait for test results before prescribing PrEP? So 1 is same day, 2 is wait for lab results, 3 is I haven't prescribed PrEP, and 4 is something else. Okay, and it looks like the majority wait for lab results, but we still have about a third that do same-day starts, which is great. What about the panel? Do any of you do same-day starts?
So this is Jeannie. I'll start. I'm comfortable doing it depending on the patient, right? It's really context specific. So if it's someone in whom I'm sure there is no chance of acute HIV infection, obviously a good symptom screen. Someone who has not had really clear high-risk exposure recently enough to make me concerned they could have undetected acute infection. Somebody who's ready to take it and has really passed the pre-contemplated phase. Then I think a same-day start is perfectly reasonable.
Great. Let's just review a little bit of data on same-day starts. So these were data that were presented at CROI last year from New York City Sexual Health Clinics, in which they took PrEP candidates. They had almost over 1,400 PrEP candidates, and they screened them for kidney disease, chronic Hep B infection, and acute HIV signs and symptoms. And if they didn't have any of those things, they went into an immediate PrEP arm shown on the left, and if they did, then they went to delayed PrEP on the right. And you can see that 97% of people screened able to get immediate PrEP. And then of those, only 2 had a GFR of less than 60 so they were started on PrEP immediately, but their labs were drawn. 2 were found to have a GFR of less than 60, 2 were HIV positive, and so in that group, PrEP was stopped immediately, and they were able to do that within a couple of days. And then the other group, over 99%, were able to continue on PrEP. Whereas for the group that had delayed PrEP, you can see that some had a GFR of less than 60, a couple were HIV positive, a couple were hepatitis B surface antigen positive. Overall, 14% didn't qualify for PrEP. So 86% did qualify for immediate PrEP or would have qualified for PrEP. But only 35% came back in. So there are some advantages to doing same-day starts it's sort of the bird in the hand idea. And so where you think, as Jeannie was saying quite thoughtfully, you've got someone who you have ruled out HIV infection and someone in whom you would really like to get them started on PrEP on that day and they're ready to start PrEP. You can start them same day, get their labs at the same time, as long as you have a mechanism for very close follow-up in case you do find that they have a contraindication to PrEP. So I think Jeannie's going to talk about this a little bit more, but I was just interested in hearing how you're handling PrEP prescriptions now in the time of COVID. So do you require 3 monthly clinic visits and do 3-month refills? Are you providing extra refills without additional HIV testing? Are you doing home testing without any HIV STI testing? Are you doing home HIV and STI testing and then refills? Are you not prescribing PrEP or are you doing something else? Okay, so the most common one is that people are sticking with 3 monthly visits and 3-month refills, but there are some additional people doing additional prescriptions without additional HIV testing. Okay, let's move on to the first case. We have a 22-year-old man who has sex with men who comes to your office seeking PrEP. He has multiple partners, never uses condoms, and his most recent receptive anal sex encounter was 48 hours ago. He's asymptomatic. What do you recommend? Do you send an HIV test to the lab and start PrEP if the test comes back negative? Do you start PrEP today, or do you start PEP today? Okay, so we have about half we're going to start PEP today. And let's talk about what the panel would do in this situation. You've got somebody who's coming in to start PrEP, but they've had a recent exposure.
So I think the fact that the person came and is really important, because I find it as an opportunity to start the dialogue. But more importantly, in this individual, you're within 72 hours, and I think starting PEP and then transitioning PEP to PrEP will be very important. Or you may need to transition PEP to treatment, right? Because he may come back and be infected. But I think starting him on PEP makes sense at this point.
Yeah. And so go ahead.
Oh, no, I was going to agree with Carlos. He would have to work pretty hard for me not to advise him to have post-exposure prophylaxis. He's never, it depends a little bit on the high-risk nature of his partner, but I think all bets are off, and to really be sure, you would want to do a PEP to PrEP transition.
Great. So this is sort of a slide as a reminder that we do have post-exposure prophylaxis that we want to be able to take advantage of, and that's for anyone who's had a high-risk exposure, who's had a high-risk exposure within 72 hours of a high-risk exposure. But as we know, as early as possible is actually best. You want to get lab tests on them, and obviously you're going to, as Carlos was saying, you want to be sure that they're not actually already HIV infected, in which case your PEP is really starting treatment. And you are starting a 3-drug regimen, so that's the difference between a PEP regimen and a PrEP regimen. PrEP regimens are generally 2-drug regimens, although we'll talk a little bit about cabotegravir in a little bit. And then you can just seamlessly transition after 28 days. If they have remained antigen antibody negative, you can just transition them to 2-drug post-exposure, pre-exposure prophylaxis. Okay, let's go to our next case. We have a 21-year-old woman who asks you to prescribe PrEP. She states that she always uses condoms with her multiple sexual partners, but she'd like to stop using them. So what do you recommend? You don't offer PrEP because condoms have worked well for her up to this point and you don't want to risk STIs. You don't offer PrEP because it actually doesn't work all that well in women. You offer PrEP but tell her it works less well if she has STIs. Or you offer PrEP and counsel that only condoms will prevent STIs, but let her make the condom decision. Go ahead and vote. Okay. So
that made me feel good.
Good. Go ahead, Carlos. Tell us about.
That was the answer we needed to see, right? That made me feel good, because number one, I think that yes, condoms, work to prevent HIV and STDs, but PrEP works a lot better to prevent HIV. And I think that just because somebody's using PrEP, they should continue using condoms to prevent STDs. And I also think that there's a lot of myths that PrEP doesn't work in women, and I think we've seen over and over that PrEP works in women if women take PrEP. So the fact that she wants to take PrEP, again, I find patients that come in and say, I want to be prescribed, as it'll be really hard to say no to somebody who says that. So Your option has to be either 3 or 4, or a combination of both, and 4 sounds like the right one, because you don't want to say take PrEP but forget about your STDs. You want to say take PrEP and continue using condoms. And I think we need to do a much better job getting that message out.
Great. Anyone else have anything to add? I'll just show the typical slide that graphs adherence on one axis against effectiveness on the other. And what you can see is with all of these.
It's not moving forward, Susan.
Sorry. Can you hear me?
Yeah, now it's fine.
Everything's
Okay.
fine.
So if we look at adherence on one axis and effectiveness on the other, these are a number of large efficacy studies, and you can see that men who have sex with men, for the most part, had high levels of adherence, as did these heterosexual serodiscordant couples and one study in heterosexuals. The reason for this, I think, largely myth about PrEP not working in women is that effectiveness was quite low in a number of studies where adherence was quite low. And there is a meta-analysis that was done that shows that, yes, PrEP does work in women if they take it regularly, and with higher adherence, you get to a lower relative risk of HIV acquisition. But we do have to remember that the PK is somewhat different in women than it is in men, or it's different for vaginal sex rather than it is for rectal sex, and that tenofovir concentrates at 10 to 100-fold higher levels in rectal than vaginal tissue, and it's cleared more rapidly from vaginal than rectal tissue. And so for that reason, we think that women really need to take 6 to 7 pills per week in order to maximize effectiveness, although there have been some demonstration projects that suggest that they might still have high levels of effectiveness even with lower levels of dosing. But we do counsel women to try to adhere on a daily basis to PrEP. The question about whether or not STIs reduce the efficacy of PrEP, there are good data now from randomized controlled trials, the iPrEP study and the Partners PrEP study that showed no difference in efficacy of PrEP despite high levels of STIs, and the same thing in open label studies in the PROUD and US MSM PrEP demo study. Very high rates of STIs and yet very high levels of PrEP effectiveness. Okay, we'll go to our next case. Your 26-year-old transgender female patient says she's just heard about a new long-acting injectable PrEP agent and she'd like to learn more about it. What do you tell her? Do you tell her that long-acting cabotegravir is given as 2 injections every 12 weeks for PrEP? That long-acting cabotegravir was shown to provide a higher level of protection than TDF-FTC, but only for men who have sex with men? That long-acting cabotegravir must be given with a 1-month oral lead-in and a prolonged oral phase when discontinued? Or that long-acting cabotegravir should be combined with long-acting rilpivirine when used as PrEP? Go ahead and vote. Let's see the results. Okay, so
you got a very informed crowd. I feel good about this.
Yeah. Okay. Oh, I see. Okay, sorry. I needed to scroll down. Yes, we do have a very informed crowd. So, who would like to speak about cabotegravir?
Let me unmute myself. Sure. So I think that probably the brightest light in the recent pandemic gloom was the results of HPTN 083 presented by Rafi Landovitz and colleagues at the recent IAS meeting, and really astonishing analyses that initially, as Susan's probably going to talk about, showed significant protection, basically non-inferiority, but ultimately with more seroconversions analyzed showed superiority to cabotegravir. So really exciting. The other point I'd make about that study is it was a really diverse group of MSM, as you'll hear. So very different than the Discover trial, which of course looked at TAF versus TDF, which was a very mono kind of homogeneous group. So really exciting. Will that happen in women? We won't know till maybe later this year. Susan, are you going to talk about it in HPTN 084? And we won't know in pregnant women or breastfeeding women for God knows when, which I cannot help but saying. So I'll turn it over to you. Do you want me to say any more?
Okay. No, that's great. Thank you. So you summarized it beautifully. So cabotegravir is an analog of dolutegravir. It's an integrase inhibitor. It's got a very long half-life in its oral form, but it's got an exceptionally long half-life in its injectable form. And there are 2 efficacy trials right now of cabotegravir long-acting. The HPTN 083 study, which was what was reported at the AIDS 2020 meeting, and HPTN 084, which is a study in women in sub-Saharan Africa. Both of the studies are double-blind, double-dummy, which means that everybody's getting an injection and everybody's taking a pill. It's just that for half of them, they're getting an active injection and a placebo pill, and the other half are getting a placebo injection and an active pill. Both of them have 3 steps. There's an oral lead-in phase for a month to be sure that it's well tolerated, because once it's injected, you can't dialyze it off, and so you want to be sure that it's well tolerated. Then there were loading doses at 0 and 4 weeks and every 8-week injections, and then an oral phase to cover that, the tail that we'll talk about in just a moment, where you've got low levels of drug persisting for actually several years, a number of people. Both trials were using FTDF as the comparator, and there are 2 bridging studies in adolescents, one in men who have sex with men and transgender women, and the other in cisgender women. So the study, we initially heard that in May of 2020, the DSMB met for a planned interim analysis, and they stopped the blinded phase of the study because it met the pre-specified non-inferiority early stopping boundaries. And at that time, we learned that the overall incidence was less than 1%, which indicated in this high-risk group of individuals that probably both arms were working, and at that time it was at least considered to be non-inferior. Cabotegravir was non-inferior, but as Jeannie mentioned, after doing a thorough analysis, they found that cabotegravir was actually superior to FTDF with an odds ratio of 0.34, meaning a 66% reduction in HIV acquisition in people getting cabotegravir compared to FTDF. Now that appeared to provide protection in all subgroups by age, race, ethnicity, men who have sex with men and transgender women. All of those groups seem to at least be non-inferior, if not superior, although there wasn't power to look at superiority in the subgroups. Injection site reactions were higher in the cabotegravir arm, 80% versus 30% in the placebo arm, with 2% discontinuing. But a little caveat, 25% in each of the arms dropped out by 2 years. So we don't know if that's because they didn't want to get the injections, they didn't want to take the daily pills, or there were other life events that made them drop out of the study. But for the people who remained in the study, injection site reactions as a cause of discontinuing was quite limited. And I just want to point out that what Jeannie said was also really important. There were 12% of the population were transgender, as opposed to the Discover trial where only 1% were transgender. And 50% of the U.S. participants were African American or Black. And so they really did recruit a very diverse cohort that reflects the epidemic in the MSM and transgender populations. These are just this is a slide of the actual results that show that there were 13 infections in the cabotegravir arm, 39 infections in the TDF-FTC arm, and it actually was not only non-inferior, but was actually superior with this odds ratio of 0.34. Now, there are a number of unanswered questions about cabotegravir long-acting. As Jeannie also mentioned, the HPTN-084 study is nearly fully enrolled, and so we don't yet know whether or not it works in cisgender women. We also don't know yet what the adherence was like in each of the arms and why the breakthrough infections occurred in each of the arms. In particular, we're interested in what the drug levels were at the time of infection, and that's particularly true for the cabotegravir. There were 5 people in the cabotegravir arm who seemed to be getting their every 2-month injections, and yet they became infected. And so the question is, what were the drug levels in those individuals, and can breakthrough infections still occur in the setting of adequate drug levels? When the breakthrough infections occurred in the oral run-in phase of the cabotegravir long-acting arm, because again, there were several that occurred in that arm, in that component, that phase of the study, was it that also due to PK, or was it due to something else? And was there transmitted resistance? And then the really critical issue is, did resistance develop after infection in each of the arms? And in particular, we're concerned about that because of this long tail that I mentioned. If you look at week 60 or week 76 post the last injection, and this is from phase 2 data, you can see that nobody still had 4 times the PAIC90, which was the target that they were shooting for, which is not surprising given that you need injections every 8 weeks to keep yourself at that level. What was concerning was that 13% of the men and 42% of the women at week 76 had low levels of drugs still present in their blood. And so the concern there is that you might have too low a level to provide protection against acquisition, but high enough to select for resistance. And then the question, of course, is if you select for resistance, are you wiping out the entire integrase class, or is this specific to cabotegravir? And so that's a great concern. There also are logistical concerns that we need to consider. This requires bi-monthly injections, and they're gluteal injections, so it's not quite as easy to do in the pharmacy waiting line. But I think and if you got the 1.1 million people in the United States for whom PrEP is indicated, that would be 6.6 million injections a year. So we're going to need to figure out how we actually integrate this into clinical practice. Can this be done outside of the clinic setting in some way? And so there are a lot of logistical questions to still be answered. So let's turn to the next case.
Let me just,
go ahead. Yes.
Say, Susan, I think that we need to also caution people that while this was very good, not everybody wants this. I can tell you several of my trial participants who were unblinded and are in the oral drug and are doing fine. They said, I don't want to switch to an injection. I'm fine taking pills. So if you're taking your Truvada and it's working for you, I want to say that when we say here it was superior, it was superior because people stopped taking their meds. But if they were taking their Truvada, it was just fine. So if you are doing your oral PrEP with pills and you're adhering with it and you're doing fine, you don't need to switch to an injectable.
Yeah, and if I could just add too, sorry, Susan, there's a lot of discussion, when these studies were being designed about the fact that these types of injections would be very familiar to young women who are used to getting Depo-Provera or DMPA for contraception, but that for other populations, particularly young men, this would be a real tough challenge to kind of have a lot of acceptance about. So it's really interesting to think about that and then see what's going to happen with 084 and think about particularly young women and young men who really need access to long-acting biomedical prevention.
Yeah, excellent points. Thank you both. Okay, let's go to our next case, which is a 48-year-old man with hypertension who comes in requesting PrEP. He has multiple partners, frequent sex, and frequent STIs. His creatinine is 1.7. Creatinine clearance is 61 milliliters a minute. What would you do? Do you prescribe daily TDF-FTC? Do you prescribe daily TAF-FTC? Do you prescribe every other day TDF-FTC? Do you prescribe pericoital or 2-1-1 PrEP, or do you tell him he should use condoms? Okay, so good. We've got 86% saying prescribe TAF-FTC. Is that what the panel would do?
Yeah, I would do TAF-FTC with a little bit of Doxy. But we can talk about that later.
I think that's coming up in my talk.
Exactly.
Yes. Okay. So let's close the. Okay. So just to let you know that in general, TDF-FTC is well tolerated. What we've seen in other studies is that if you start off with a baseline estimated GFR of less than 90, or you're a little bit older, you're more likely to have a drop in GFR. In the Partners PrEP and Partners Demo study, the same risk factors were also the case, as was being lighter weight. But, sorry, here we go. Over 75% of the creatinine increases were unconfirmed on repeat testing, and there was no difference in picking up true renal effects based on every 6-month testing, so you didn't need to test every 3 months. In the IDU study, there was no effect of recent IDU on creatinine, and it was more likely, you were more likely again to have renal effects with increased age. But in all of these studies, creatinine reverted to near baseline after the trial, and rechallenge has been used successfully. So that was what we were left with before we had the Discover trial. We did just mention the Discover trial. It unfortunately only had about 1% were transgender women, so little information in transgender women, but close to 5,400 men who have sex with men who were randomized to either FTAF or FTDF. And the results were that, and these were just presented at CROI in 2020, the follow-up data, that FPAF was non-inferior to FTDF. So not superior, but non-inferior to FTDF. The safety data favored FTAF in terms of bone mineral density and renal function, but the differences were really minimal. It was a 1 to 2% difference in bone mineral density at the spine and hip, and no difference in fractures, and only a 4 milliliter per minute difference in estimated GFR at 96 weeks. And you'll see that in your pre-test and post-test, that the differences were really minor, and that was the only difference really in terms of renal function, was a 4 milliliter a minute difference. And then favoring FTDF were lipids and body weight, but again, very minimal differences between the two. An 11 milligram per deciliter lower total cholesterol, no difference in total cholesterol to HDL ratio, and only a 1 kilogram difference in body weight. So Julia Marquez created this infographic that providers can use in trying to decide what do you do, which do you prescribe for daily PrEP, TDF, FTC or TAF FTC. You can see that the pill sizes are different. Only FTDF has been tested in heterosexuals and people who inject drugs, whereas both have been tested in men who have sex with men and a small number of transgender women. The safety, again, favors slightly towards FTAF for bone mineral density and creatinine, whereas LDL and body weight favor slightly FTDF. But the main difference is going to be in cost. Right now they cost approximately the same, but FTDF is going to be going generic in 2020. And so that should bring the price down, if not immediately, over time. Any other comments about this before we move on? Okay. So the next case is a 34-year-old MSM who has sex with partners approximately, and I can't see this, sorry, twice per month. He doesn't want to take daily pills because his sexual exposures are relatively infrequent, but he doesn't always use condoms. So what would you do? Do you encourage him to use condoms? Do you think because his exposure is relatively low, he doesn't really need to worry about PrEP? Do you encourage him to take daily PrEP? Do you have him start PrEP 7 days before sexual episodes, or do you prescribe on-demand or 2-on-1 PrEP? Go ahead and vote. Okay, so we've got almost 3/4 who are saying that they prescribe 2-on-1 PrEP, which is great. Do the panelists use 2-on-1 PrEP?
I don't use it myself.
Personally,
Prescribe it, sorry.
I would if I needed it.
Yes.
I think it's a great way to prescribe PrEP to somebody like the patient here. I think the infrequent sex. If I recall, there's a paper suggesting there's an analysis from Jean-Michel Molina in Lancet HIV not too long ago, suggesting that as little as 5 episodes of sex per month, you're still doing well if you're doing this regimen. So
yeah.
You don't need to go to daily PrEP. If you're having, once a week sex, you're probably fine using, 2-on-1. And I think the challenge I always found is that at least French men seem to know when they're going to have sex and they can plan this appropriately. It's a little harder when you really don't know.
That's because they open a bottle of wine first.
Right, exactly.
First, before or after.
Yes.
Yeah,
right.
I think that's true. And, even when you look at the original iPrEP study, right, it was interesting. I mean, what was the average number of doses per week? Wasn't it 4 or so? So like 4 or 7 days, I think people were taking it, even using it in this regimen. So I kind of think of this regimen as a spectrum where people may just end up, as long as they have 4 anyway, you're probably getting enough coverage if you're not having a lot of sex every day. But I would be very comfortable in this man doing 5.
Yeah, okay, and that's exactly right. So just for people who are not aware of 2-on-1 PrEP, it's 2 tablets, 2 to 24 hours before sex, 1 tablet 24 hours after that, and 1 tablet 24 hours after that. So that's why it's called 2-on-1. It could be called 2-1-1-1-1, depending on how much you have sex, because you continue taking daily pills until 48 hours after the last dose if the last pill was within 7 days, then you don't need the loading dose of 2 pills. You can just use a single pill to start. But as was discussed, it was very highly effective. In the RCT, it was 86% reduction in HIV acquisition, and in the open label extension, a 97% reduction compared with the placebo arm. But as Jeannie pointed out, people were taking on average 4.5 pills a week, which is essentially equivalent to 4 pills a week, which from this modeling data where we gave people directly observed therapy 2 days a week, 4 days a week, or 7 days a week with FTC, tenofovir, TDF. And this was in a low-risk group of individuals, and then we're able to map onto what were their drug levels like and mapped onto the iPrEP study. You can see that with 4 doses a week, you're nearly as efficacious as 7 days a week. And so that's why we say that MSM probably only need 4 doses a week. And so the question was, does this work for people who are having even less frequent sex? And so they did do, Jean-Michel Molina and his team did do another analysis of people who were taking PrEP less frequently and found that in that group as well, it was highly effective in preventing HIV acquisition. So 2-on-1 is a great regimen in some cases. CDC still continues to recommend only daily PrEP, and it's the only licensed indication by the FDA. But the IAS-USA guidelines do recommend 2-on-1 PrEP as an alternative to daily PrEP for men who have sex with men, and WHO has endorsed 2-on-1 PrEP as well. You do need to be able to plan ahead for that pre-dose. So you do need to be able to know that you've got at least 2 hours before you're going to have sex. And you need to know that you can take the post doses, and people should be counseled to use it with all their partners, not to pick and choose with whom they use it. It's only been tested in FTDF, so it shouldn't be used with FTAF. And daily PrEP is the only recommended option for cis and transgender women and people who inject drugs because there aren't data, and also the PK may suggest that it may not be as highly effective in those populations.
And Susan, I would say things just to remind people, we are not using this, is not recommended in women also. And the reality is, even though CDC does not recommend it, it is really, this is being used in the community all the time, and everybody knows about it.
Yes. Thanks, Carlos. And this is sort of the head-to-head comparison. You can only use it in men who have sex with men. You shouldn't use it if somebody's got chronic hepatitis B because it can trigger a flare. You do need to be able to plan, and it may not have as much forgiveness. But other than that, it's a very reasonable option for people who can plan ahead for their sex and are having sex less frequently. Okay, let's go to the next case. Your 31-year-old patient on PrEP comes in for his routine quarterly lab tests. His 4th-generation antibody test comes back positive, but the confirmatory test and viral load come back negative. So what do you do in this situation? Do you repeat the test but continue PrEP as you assume the 4th-generation test is a false positive? Do you repeat the tests and stop PrEP but start ART for acute HIV infection? Do you repeat the tests and stop PrEP until you can determine what the infection status is, or do you do something else? Okay, let's see. So we've got, this is in accordance with the fact that there is no right answer here. So we've got a spectrum of responses here. How would the panelists handle this kind of situation? Anything to say?
Sure, I can start. I don't think I would treat him for infection at this point because I don't believe that he has a confirmed test. The 4th-generation antibody test is relatively specific, and this would be if it was a false positive test, given the confirmatory test and the viral load, that would be the concern. I think that number 3 is the safest thing to do. I could see doing number 1 because at the time that your 4th-generation antibody test comes back positive, you should detect a viral load, but it depends on the quantification level of the viral load. It may not be a highly sensitive test. So I personally would feel the most conservative thing would be to stop PrEP, have a conversation with him about the implications of stopping PrEP. Really, really important, right? Because there could be a big downside to stopping PrEP if he's going to go right out and have a very high risk exposure. So it's a conversation to have, but I would be more comfortable doing 3. And then the question would be, when do you repeat the test? I'd probably bring him back in a week to 10 days.
Yeah.
I made that up. I don't know if that's right.
So I agree. I mean, as you say, this is a really difficult situation.
Yeah.
We're seeing this with PrEP all the time. First of all, seroconversions are not what they used to be. Finding somebody who was infected was really easy, but on PrEP it's harder. And this could easily be somebody who wasn't taking his PrEP very well, got infected, then said, oh my God, I better take my medicines, took their medicines, and now they have a suppressed viral load because they're in effect partially treating their HIV.
Great.
And that could be the situation here. So I think you can go in many different ways, but I would have a conversation about adherence with this person. And if I truly thought this could be an infection and he's got a suppressed viral load because he started back taking his PrEP, I would probably do number 2. I would repeat the test and up his regimen to a 3-drug regimen, waiting to see what happened. But if you did number 3, you could probably also get away with it. And again, if he's infected, you're going to see his viral load come up. But this is a very difficult situation, and we've seen this over and over.
So for the panelists, what about getting an HIV DNA value?
I mean, you could, if he was in a study, you would, but in 083, but the reality is that it's not, I don't know how available it is for your average person providing primary care for somebody in this situation. And I also think that, that would be more important to adjudicate whether or not he had covert or suppressed infection, possibly as the result of taking PrEP, which on Truvada, I think would be less likely than it would be with something like cabotegravir.
So this is just a slide to remind us that the viral RNA is going to come up first, and then you get your antigen, and then you get your antibody. And so sometimes, for instance, if you have a positive 4th generation and a negative confirmatory, but you do a viral load and that's positive, that may be because you're just early in infection and the person has not yet, they've got antigen, but they don't yet have antibody enough to trigger a 2nd generation test, which is what some of the confirmatory tests are. In this situation, you have a negative viral load, and so you're stuck with this quandary of what do you do in this situation? So clearly you do repeat the test, and if you can, repeat it with a different manufacturer, that's all the better, just in case you see differences in response. But if the person has been adherent, you may want to continue them on PrEP because you'll maintain protection. But, of course, if they're actually infected, you run the risk of resistance. If you know that they were not adherent to PrEP, then you might be more concerned about them being actually infected. But some people would not want to start someone on lifelong therapy without actually having confirmation of infection. The most conservative thing to do is to stop PrEP and reassess HIV infection status, but that presumes that the person will not be exposed during that period of time when you've stopped PrEP, because you wouldn't want to put them at risk. So these are very thorny situations to resolve, and there is help. There's a PrEP line, a warm line from 11 a.m. to 6 p.m. Pacific Standard Time that you can call to get expert advice if you do have these unusual serologic responses, which we're seeing more frequently now with PrEP. Okay, let's go to the next case. A 28-year-old HIV-negative woman is in a serodifferent relationship with an HIV-positive man. He's newly diagnosed and not yet stably virally suppressed. The couple wants to have a baby. What do you recommend? Do you wait for the male partner to become fully virally suppressed for at least 6 months before attempting pregnancy? Do you use PrEP because it's safe periconception and in pregnancy? Don't use PrEP, its safety is unknown. Use sperm washing instead, or something else. Okay. So about half of the people say that it's safe. Go ahead.
Yeah, no, I think I would go with number 2. I think I would prescribe PrEP for this person, and I mean, I'm not sure if the partner, is going to become suppressed, or if the partner is going to be around and then not pee or not take the medication, and the person is, she needs to be on PrEP right now, whether she, wants to have a baby or not. I think at this point in time, she should be on PrEP because he's not suppressed yet. So regardless of pregnancy, she needs to be on PrEP. So I would go with number 2.
Yeah, great. Well, we know that pregnancy is a particularly vulnerable time in terms of HIV acquisition as well. These are data from over 2,700 HIV uninfected women and serodiscordant couples in which they were able to actually adjust for the viral load in the male partner. And you can see that the risk of pregnancy was 2.76-fold higher. The risk of HIV acquisition in pregnancy was 2.76-fold higher than in non-pregnant women, and that it actually rose sort of monotonically from early pregnancy to late pregnancy to postpartum, which was the riskiest period of time. So she, as Carlos points out, she would have been at risk anyway, and now she may be at increased risk if she's trying to become pregnant. There is good news in terms of safety. There are 5 studies of over 1,000 PrEP-exposed women during pregnancy that have shown no difference in miscarriage, congenital anomalies, or growth through 1 year of infancy, and a systematic review of tenofovir exposure in pregnancy with 26 studies in HIV-positive women and 7 in HIV-negative women, again showing no adverse pregnancy or infant outcomes. So PrEP should be safe in pregnant women and can be used in that situation. I'm going to just quickly do the last case. A 29-year-old woman in a serodifferent relationship would like to stop using condoms. Her partner's not virally suppressed. She wants to know how long it will take her, how long she has to take daily PrEP before she's protected. What do you tell her? 3 days, 7 days, 20 days, 28 days, or I have no idea. Okay, 7 days seems to have won the day, and 20 days is next in line. And that makes sense because, in fact, if you can close that out, the poll, in PBMCs, you achieve 89% achieve the EC90 after 7 doses. So that's good news. For men who have sex with men, you can recommend either 7 days before or a double dose start like in 211 PrEP, and probably to stop 2 days after the last sexual act. CDC still recommends 20 days before for women, but there's a growing consensus that 7 days is likely adequate to get up to a high enough level to provide protection. But just to remember that women need 6 to 7 doses a week, while men only need 4 to 7 doses for maximal protection. Did the panelists have anything to say about that?
No, just to add that I think it's one of the reasons that people have this sort of wrong, as Carlos mentioned, wrong view that PrEP doesn't really work in women. It takes longer to get therapeutic. I mean, again, there's a little bit less forgiveness, but we really need to emphasize that it does work if it's taken daily. Great.
And I think we're supposed to turn to the Q&A now. We don't have time to talk about about hormones, but or these other things, but let's just go to the Q&A session.
Great, thank you. Thank you, everybody on the panel, and thank you, Dr. Buchbinder. So a couple of questions. Will we ever be able to do away with the oral lead-in for cabotegravir?
It's a great question. Does anyone on the panel want to address that? I mean, I think that it's really tough because once it's injected, you bought it, you can't get rid of it. And so I think that there's going to need to be an oral lead-in. But I think what we need to know is why did the infections occur in the oral lead-in in 083?
Yeah, and I would like to see, sorry, Carlos, go ahead.
No, go ahead.
Yeah, I would like to see more detail on the oral lead-in data from 083 and 084. I mean, my sense was that it was incredibly well tolerated and that if anything, it was just the injection site reaction. So I think it's probably going to be ultimately no different than Truvada. So, who knows? But I think it's a great question.
Another question about the cabotegravir study is about the post-discharge tail, and it appeared that it was longer in women in the slide that you showed. How do you instruct people on how long to take medication after the tail, and as part of the tail, and is it different for men and women?
So what we know is that the tail lasts longer in women overall and in people with a higher BMI. And so what we don't know yet is how long you actually need to have that tail. That's another thing that we're hoping to learn from the study, is that they've only given a year's worth of coverage for the tail, but what we know is that it can last 3 years in men and 4 years in women in the more extreme cases. And so it's not quite clear how long we're going to need to cover that tail for, or if the tail needs to be covered. But the concern is that it does need to be covered, and that is one of the potential downsides to long-acting cabotegravir.
And the last cabotegravir question, can it be administered in a non-gluteal site such as the thigh?
Yeah. Yeah.
Okay.
Hopefully. That's not how it was administered here, but it could be.
Yeah.
And Carlos,
It's a large injection.
It's a fairly large injection. It's not a trivial injection.
Carlos, one thing you mentioned, and the basis of this question, is how do you diagnose acute HIV in people on PrEP? Are the symptoms attenuated and less obvious? Are the antibody tests not reliable? I mean, what's the best way to make a diagnosis?
I mean, I think all the above. I think you have to be relying on getting a discordant result, or you have to be relying on getting a low positive antibody test, or you have to be looking at viral load in some settings, and you have to, again, talk to the person about whether there could be potential signs of exposure. But, you know, the presentation is very delayed, and so is the seroconversion.
Okay, so getting away from the cabotegravir, one question is regarding not the 2-on-1, but scheduled dosing like Thursday, Saturday, Sunday, Tuesday, you know, to work around people's weekends. Is there any data supporting that?
Just the data that we have from the modeling data that suggests that 4 days a week may be okay. And so people talk about the T's and S's, the Tuesday, Thursday, Saturday, Sunday is probably adequate, but just for men who have sex with men, that's probably not true for other populations. And I didn't get to a case in transgender women, but there are some data that suggests that for transgender women, the good news is that the TDF-FTC does not interfere with their hormones. Right. So that's true for both women and men. There were data just presented at IAS, and there have been other, at AIDS 2020. There are data that are that have come out, though, from a number of studies suggesting that there may be some small decrease in tenofovir levels in transgender women who are on hormonal therapy. And so we don't really know exactly what that means. The data from AIDS 2020 suggested that there was no difference. There are other data that suggest that there is a lowering of tenofovir, and so we need to get a little more information about that.
Okay. Also about intermittent PrEP, if you had somebody who's a hepatitis B non-responder to vaccines, would you recommend a daily tenofovir-based PrEP, or would intermittent tenofovir or TAF-based PrEP be efficacious? Do we have any data on preventing Hep B acquisition?
Well, I think I don't think I would necessarily base my decision about 2-on-1 PrEP on whether if we know that they're chronically infected with hepatitis B, then I wouldn't use it.
This is PrEP for hepatitis B.
Yes.
Yeah. Somebody who didn't respond to the HBV vaccine. Any thoughts?
Kind of a niche question.
Yeah, it kind of is.
But it's a great question. I'm sure it's happened. I've never encountered it. I guess I would say, I would encourage it. I think it couldn't hurt, and it could probably protect. But what the threshold of the dosage level that you would need, I have no idea. I'm sure somebody knows, though.
Yeah, I don't know.
Yeah, I think it's an area where we don't have any data. So last question.
So it must be, if the area we don't have data, it must be like COVID.
Yeah. For those using TAF for PrEP, how long do you recommend that they be on it before they consider themselves protected the same as for TDF or different?
It's a great question. I would assume that it would be about the same as for TDF, and so I would use the same thought. The thing is that what we don't know is if it works as 2-on-1, and so I don't know that the double dose beforehand is going to be appropriate for somebody, but certainly for if you, it's probably true that people are protected long before 7 days, but the 7 days is the conservative way of looking at when you have onset of full activity.
Okay, great. Well, thanks a lot, everybody, and thank you. That was an excellent discussion and presentation. I'll now turn it back over to Dr. Sag, who will be leading us into the next session.
Great, thank you.